So, empezamos, Matías. ¿Quieres que introduzca brevemente?
Sí.
So thank you very much for attending this webinar of SELNET. I think it's very interesting to focus on the novelties in different groups of sarcoma, soft tissue, bone sarcoma, and also GIST. So thank you very much also because your commitment with clinical practice guidelines. We already have ready to publication these guidelines in 2 different articles, but in conversations with colleagues from ESMO, they recommended to wait for a while because ESMO guidelines are in process to be submitted. So I think it should be very nice if we are able to submit our SELNET guidelines after the acceptance of ESMO clinical practice guidelines. So we have to wait for maybe a couple of months, and the work is already done. So thank you very much for your high commitment, especially for the Lyon team, Janives and Julian, because they have conducted a very nicely a very good work. And I think the final product, I think, is very nice. So I think also other headlines from SELNET, we have already more than 500 registered patients. So we stimulate and encourage those centers, partners, official partners, and associated to keep the path of this registry is very important. And we
es un webinar de sarcomas, que todo lo que me expliquen me irá bien.
Yeah, we can.
De hecho, me conecto aquí, pero me iré en el bus.
Paula, you can. Okay, so it's important to mute Nadia because, as you know, there are some.
I am
connections. Okay, so we have already almost 200 blogs already received, and we encourage as well to all those centers who are pending to send these blogs to be ready for that. So Costa Rica and Brazil are almost in the final process of approval. It has been a very long-lasting process, but in the end, if the final outcome is successful, then will be very nice. And the time we have spent, especially Celso and Natalia, will be very deserving time for this end. So I am now Matías Chacón will share this first webinar. And it's your time, Matías. Thank you very much for hosting this webinar.
Well, thank you, Martin. I guess we are on time. I appreciate a lot your work. Really, the work of SELNET is very interesting and productive for Latin America. And obviously, I have to appreciate the participation of Janives and Emanuela and Jonathan Trent to discuss about the novel therapies in soft tissue, bone tumors, and GIST. So please be quiet with your microphone, and if you have questions, please send by chat. It will be the best find, and we are no superposition between our texts. So let's introduce Janives Blay. He is one of the leaders of sarcoma in Europe in the Centre Lyon Bernard in Lyon, France. So Janives, if you are here,
yes,
you can start. Thank you. Good morning, or good afternoon, or good night. I don't know.
So for us, it's good afternoon, and for you, it's good morning, probably. Thank you, Matías. Thank you very much, all, and thank you for the invitation. It's really a pleasure to be here, and I must say, I really love this SELNET project. It's so good to work with you. So I'm going to share my screen. Let me check. Here we are. So what I will try to do in the coming minutes is, let me check if I can share. Oops.
Yeah.
Here we are. For some reason I cannot. Oops. Okay. Do you see my screen?
Yeah.
Okay.
Sure.
So what I will do in the coming 15 minutes is to discuss on soft tissue sarcoma, new therapies, while Manuela will focus on bone and John will discuss on GIST. So I will focus. So these are my disclosures. I will discuss on connective tissue tumors of the soft part, and this is quite a complex group of disease. And actually, probably the presentation cannot cover all the strategies which could be accomplished for the treatment of these tumors, simply because as we stand right now with the WHO 2020 classification, we have now more than 150 different histological subtypes of soft tissue tumors, not taking into account the molecular subtypes. And when you look at, and you can see this slide, and this is normal. This is only the list of different histotypes according to the WHO 2020 classification. And in blue, light blue, phase 2, dark blue, randomized phase 2, green, randomized phase 3. So you can see that here, these tumors, which are actually with an incidence which is comprised between 1 per 100 1 per 100,000 per year and 1 per million, are the majority of tumors which have been proposed for clinical trials, whether they are phase 2, phase 3, or randomized phase 2. While all the others, those with an incidence inferior to 1 per 10 million or inferior to 1 per million, are very seldom proposed for clinical trials. And for this reason, we don't know what to do for these tumors. Yet things are very much changing. And one of the reasons why they are changing is that we understand better the biology of these tumors. And by guiding the treatment according to the presence of the molecular alteration, we have made some significant progresses. So what I will do is really to focus on this question on how molecular biology, and we are going to see also cellular biology, guides the treatment of our patients. Actually, besides GIST, which John is going to cover, which is always an intensively active field, for soft tissue tumors, probably started with this drug, imatinib, again, in DFSP in the mid-2000s, where actually retrospective studies led to the demonstration of the activity of these tyrosine kinase inhibitors in these tumors, which are actually expressing PDGF receptor alpha in a mutated format. In this case, it's a translocation. And the important part of this project was that actually the drug was approved on both sides of the Atlantic without any phase 2 studies. These phase 2, which are presented here, took place afterwards. And by the way, needed the combination of 2 phase 2 on two sides of the Atlantic to be able to complete the study, showing a significant quality of the response and progression-free survival in this tumor. So translocation involving ligand of PDGF and the activity of PDGF receptor inhibitor. The same is true for another translocation, which is a translocation observed, in this case, not in a sarcoma, but for a locally aggressive connective tissue tumor, which is called PVNS, pigmented venodular synovitis, also giant cell tumor of the tendons and the soft part. This is not a sarcoma, even though metastases do happen quite rarely in this patient. And we had in our experience surveying the whole country, less than 5 patients affected with metastasis, but with documented metastasis. The point is that these tumors have a translocation, which is involving another growth factor, which is CSF1, which is very close to the PDGF receptor alpha I was just mentioning. And these patients who have tumors often around the knee, ankle, the hip, sometimes a superior limb, actually have no other solution than trying to block actually these activated receptor. And that was a topic of a retrospective study, followed by a prospective study for a relatively lousy CSF1 receptor inhibitor, which was in this case nilotinib for this phase 2, but imatinib is also active, leading to these two type of approach, which are actually tyrosine kinase inhibitors or antibodies to block the receptor, which is activated by the overproduction of the ligand resulting from the translocation. So with the antibody mactuzumab, which actually was developed by Roche, and possibly we are going to have a new trial from a different company in the future, large volumetric response rate in the range of 60% for the patient receiving the antibody. If you use a less efficient tyrosine kinase inhibitor, in this case nilotinib, we can see that shrinkage is less important. Still, some patients do achieve tumor control. So it works. And it leads to a randomized study, which was done around the world with pexidartinib, a specific CSF1 receptor inhibitor, which demonstrated very nicely the shrinkage of the tumor with a tyrosine kinase inhibitor as compared to the placebo, and led to the approval of the compound on this side of the Atlantic, but not on the other side of the Atlantic. And I use here a photograph which has been presented by Sylvester from one of our patients, which shows the type of response that we have with this agent. PVNS here of the hand, which was so big that all the fingers were not visible at the beginning, and after the treatment with pexidartinib, a shrinkage of the tumor. So these are examples of active treatment in the front of a mutation, which is a translocation involving a ligand or a receptor. Here we have another example of a very good inhibitor of mutated activated tyrosine kinase, which is ALK, in the form of inflammatory myofibroblastic tumors, which are very rare tumors. It's about, well, probably 3 per 10 million per year in a country like France, and very little treatment option if the patient is progressing. With ALK inhibitors, because ALK here is a kinase which is fused in the fusion gene. With ALK inhibitors, tumor control is observed for majority of patients, and sometimes very long. One of these patients included in the CREATE study has been was treated on the center, is now after 7 years still controlled from brain mets and multifocal mets with single treatment crizotinib since the beginning. And this led, of course, to the discovery and the identification of these new classes of tumors, which are spread all over histotypes, not only sarcoma, with NTRK fusion proteins, which led to the development of TRK inhibitors, larotrectinib, entrectinib, and several others. Here in blue, you can see the sarcoma, and you can see here that all sarcoma, almost all sarcoma, with this exception, actually did achieve some level of response. This one was not affected with the translocation. And if you focus on sarcoma, you see that soft tissue, infantile fibrosarcoma, the rare gist and the rare bone are all responding in front of this treatment. So translocation, fusion gene with a ligand or a receptor, super rare, but very well responding. And responding, as you can see here with larotrectinib, for a very long period of time. This is the duration of response. This is overall survival. These are figures that we observed at the beginning of imatinib for gastrointestinal stromal tumors, actually. And I like to quote here this picture, which was presented by Mrinal Gunder from the MSKCC some 3 years ago, which is so spectacular in terms of shrinkage of the metastasis in this tumor. So kinase which are affected by translocation or ligands are good targets. What about kinase mutation? I will not speak, of course, of GIS, but I wanted only to focus on the super rare subset of sarcoma and connective tissue tumors which are affected with BRAF mutation. And we know from this basket study that not all tumors affected with BRAF mutations do respond. It depends on the histotype. It depends on the nature, on the sub classification of the histotype. What is interesting, this is not published as part of this publication. What is interesting is that some connective tissue tumors with BRAF mutation really do respond very well. This is a case of Langerhans cell histiocytosis and Erdheim-Chester disease, which are extremely rare entities at the borderline between hematological malignancies and connective tissue malignancies. But here in this excerpt from the previous publication, we can see that the patient do respond, and we have still unpublished phase 2 study of basket studies, including a few sarcomas outside of the histotype. There were 4 patients with sarcoma affected with BRAF, and all of them a BRAF mutation V600E, sorry, I should have precise that. And they all responded very well and for a very long period of time to a single agent vemurafenib. Probably this is a pathway which is activated, by the way, because if you have a downstream mutation on histiocytic sarcoma, which is very connected to this group of disease, MEK1 in this case, very nice responses were reported again by our colleague Mrinal Gunder from the MSKCC. All right, so it looks very nice because we have translocation, we have mutation, and everybody seems to respond. Unfortunately, this is not the case always. We have what is very much more common in our practice of sarcoma treating centers, MDM2 amplification associated with CDK4 amplification in well-differentiated or dedifferentiated liposarcoma, happening also in superficial bone sarcoma, happening also in intimal sarcoma, and the suspect here play a key role as oncogenic partners in these tumors. And we know from these molecular analysis of the somatic alteration that these are the principal, if not the only, mutation which are observed on these tumors. We should have expected a very good response to single agent inhibitor of MDM2 or CDK4. And you can see here MDM2 inhibitors, which, okay, provide some level of tumor control within a 5% response rate and with median progression-free survival in the range of 6 months, but nothing long-lasting, nothing spectacular as we have seen just before on the other examples. Actually, it's probably the combination of MDM2 and CDK4 which was done and completed, not yet published, so the publication is ongoing, which is probably going to find us some solution. Here, one of the patients included in the phase 1 in our center. What I can tell you, and this has been published in the ASCO in the first preliminary format, is that about 30% of the patients do achieve tumor shrinkage in this trial, and more of them are stabilized. What is still striking is that it's not 100% tumor control, even though you block the 2 highly suspected oncogene playing a role in this tumor. So here we have probably missed something which is not still very clear. All right. So we are going over the panorama of the different molecular alteration of sarcoma. Let's have a look on tumor suppressor gene losses. And it's always nice to quote the work of our colleagues from the Istituto Tumori within the context of the World Sarcoma Network on PEComa. And actually, it was a retrospective study on PEComa. What was the best treatment of PEComa? What is the best medical treatment of PEComa in localized but locally advanced or metastatic format? Nobody really knew. We have seen from this worldwide study that actually cytotoxic were not inactive, but probably, and because PEComa are affected often with TSC1 or TSC2 gene disruption, mTOR inhibitors do seem to provide a longer progression-free survival than the other agents, and for some patients with very prolonged progression-free survival. But still, we are left to conclude with the majority of sarcoma, which are not affected by these different mutations, which are not affected by translocation, mutation, loss of tumor suppressor gene or amplification. So what about them? What about them? We still don't know, and we are still looking at the subsets, molecular subsets of sarcoma within them. It's not a one-size-fits-all. It's probably very narrow individual subtypes. Probably one of the very impressive results, which was produced by, again, worldwide exercise, a phase 2 study, is a result exploring tazemetostat, an EZH2 inhibitor, in sarcoma affecting, where the molecular alteration is affecting the Swiss-NIF complex, which is regulating PRC2, which by itself block EZH2, resulting basically in the EZH2 activation. EZH2 inhibitors are active in these very rare epithelioid sarcoma affected with loss of INI1, in particular when they are given upfront before any treatment. And the drug is approved in the US, and to my knowledge, it's not really approved elsewhere in the world, but a compassionate use program can be given, and the results are often very impressive for the patient who were untreated. Still, we finish also with drugs which are not so well targeted, the tyrosine kinase inhibitors blocking angiogenic processes, including the first one was pazopanib. More recently, the REGO-SARC and regorafenib study comparing Rego versus placebo showed the superiority of Rego over placebo in this study that you may have seen. What we actually explored in this the subsequent study is not only the capacity of regorafenib to control the treatment after crossover, but also for patients pre-treated with pazopanib. We observed, I must say, quite surprisingly, because we were not expecting really that regorafenib after pazopanib is able to improve in this randomized setting again, is able to improve progression-free survival and overall survival, as you can see here, with a reduction of mortality, which is not negligible in this patient population, who has been already receiving the same class of agents. So there is still here quite a mystery on how to best proceed with the use of this agent. That's going to be a key question for the future. The same is true, by the way, on the beautiful paper, again presented by our colleague Mrinal Gunda and collaborators on sorafenib in desmoid tumors. To finish up, I would like to say 3 words on immunotherapy of sarcoma. It was the ideal observation, immunotherapy in sarcoma. It was the first treatment in the MSKCC 2 centuries ago. We had hints that it could work with MTP in osteosarcoma, but it's not very well working when you look at the prospective clinical trials using PD-L1 or PD-1 antibodies. And this is one of the studies which was done in our group. Some patients do respond, but only a minority of patients. Who are those patients? Interestingly, they seem to be from 2 categories. First category is a group of patients who are presenting in their primary tumor if B-cell infiltrates, and these B-cell infiltrates, which recapitulates in what is called tertiary lymphoid structures, are rare in sarcoma in about 10 to 20%, but these are the patients who do respond to immunotherapy in these different cohorts, which were reported in Nature paper, basically the SARC 028 and the study I was just showing. This is currently being studied in prospectively, and the study has been completed and actually submitted to ASCO yesterday evening, where it is basically confirming, as we will possibly see, the outcome of patients with tertiary lymphoid structures. So first group of patients, and second group of patients, those with specific histologies, and I will not spend too much time on this one. All right, so we have work to do to complete these different boxes. New agent of sarcoma, we have many, guided by the molecular alteration, and to develop new agents, what we definitely need is collaborative international clinical trial, because not a single country is big enough to do that. Thank you very much for your attention.
Thank you very much, Shanibs. It was a pleasure to hear. We have Nadia and Thomas that are going to moderate the session or the question and answers. We have 10 minutes to do. So Nadia, Thomas, you are involved.
Thank you, Rani, for your brilliant presentation. It's clear that the approach of one drug fits all, it's no longer working in sarcoma, because you have dissected therapy in really different histologies. And I think this is the future. We have one question from the audience, very interesting, from Martin Angel, which says that taking into account the amount of different targets currently available for soft tissue sarcoma, he asks you if you consider that NGS is useful for soft tissue sarcoma patients, and how often do you request in your daily practice?
That's a very important question. Yes, I think in an ideal world, we should have NGS for all our patients with sarcoma, because it it enables you to classify the patient according to the known molecular alteration first, and of course to better classify patient with unknown molecular alteration, which we are discovering on a daily basis. The problem is that it is costly and it's not available everywhere. So this is only part of a research program which we need to find funding for. And that's very challenging. I try to convince my health authorities that it's cheaper to have 1,000 NGS analysis at the beginning and to treat accurately the patient as compared, because this is less than one course of chemotherapy, basically the cost, as compared to treating the patient without knowing exactly what we have. But I have difficulty to convince the health authorities. But I think we should move in this direction, absolutely.
Yeah, there is also the question that maybe some of the molecular changes are gained over the therapy, so over the course of the disease. So maybe we should think about repeating NGS.
Oh yeah, absolutely.
But your approach that at least once during the disease, it's
yeah, exactly. At least once at the beginning or on the primary tumor. Yeah.
We have another question from Javier Martin Broto regarding alveolar soft part sarcoma. We know that this is probably the most sensible histologic subtype for immunotherapy for PD-1, PD-L1 inhibitors. So would you recommend that kind of therapy for alveolar soft part sarcoma patients by compassionate use or trying to get access to these drugs?
Yes, this is exactly what we try to have. Doxorubicin has limited activity, as we all know. The combination treatment, which was reported by the Spanish group, is probably the best type of example that we can provide for the control of this disease, which are with this treatment achieving a very prolonged progression-free and overall survival, which is unbeaten by anything else. So I know that the health authorities are not necessarily keen to reimburse quickly, but we should definitely try to get this treatment for all of our patients with the SPS. Yes.
At the beginning, you comment that in some very rare histologies, sometimes the approval of some drugs is not based on big trials, but on a convincing efficacy data. So I think that good alveolar soft part sarcoma could be.
It's a perfect example.
Yeah, exactly. So there is another question on immunotherapy, and Martin Angel asked again. He's very active. Thank you with the questions. Do you think that tumor mutational burden is a reliable biomarker for immunotherapy in soft tissue sarcoma?
I have mixed feeling on this question. The short answer is not always. So some patients with high mutation TMB are rare in sarcoma. I think we are in the ballpark of 5% above 20, but it's not zero. Some of these patients do achieve very good responses to PD-1 or combination of PD-1 and CTLA-4, but not all of them. Also, ASPS and chordoma, which are so good responders to immunotherapy, has a TMB of almost 0 or close to 1, let's say. So I have mixed feelings. Yes, it's one of the tools that we can use. Probably we need to refine that.
Do you think CD20 infiltration, B lymphocyte infiltration is a more relevant factor, probably?
I don't want to spoil the presentation of Antoine who sent it to the ESCO, but what I can tell you, is yes, it's not bad, it's very good, but still it's not perfect. Far from that. So the problem is that we do not have a perfect marker. I think TMB has value. I think CD20 has very good value. ASPS, chordoma, yes. There is something else that we do not catch. And by the way, there are many others, other checkpoint inhibitors which are expressed on sarcoma, which we have not looked at. LAG3, TIM3, name them.
Exactly.
Now we have another question from Matthias. How we can apply novel therapies in adjuvant or neoadjuvant trials, and in that case, win those trials? What do you think?
Yeah, we try to convince the companies who are keen to help us that neoadjuvant and proof of concept studies are the way forward. Actually, I must say that we succeeded only rarely. The study I mentioned about the MDM2 inhibitor that we did in liposarcoma was actually probably the only successful example so far, at least on our side. But I think this is definitely the way to learn better. Neoadjuvant. Adjuvant, I'm a bit more split. Depends on the risk of relapse of the disease, of course.
I would be more provocative. Neoadjuvant in non-high risk localized soft tissue sarcoma, in which I could go for chemotherapy, maybe not.
Oh, you mean replacing chemotherapy?
No, I mean that.
To those patients who do not give, where you do not give chemotherapy. Exactly. Yeah, fully agree. Yeah.
Okay. So I don't know if there is any other question from the audience, because maybe, I mean, we are 3 minutes after.
Yeah. We are on time, Nadia, if you want, and we appreciate a lot the talk of Shanice. So thank you, Shanice, very much, and thank you to you, Nadia and Tomas, to participate as moderator. So we are going to next speaker, that is Emanuela Palmerini from the Istituto Ortopedico Risoli di Bologna, Italy. Emanuela, it's a pleasure for us to hear you and to listen. So the moderators will be Andres Rodriguez and Gisela Ferman. So
thank you. I will share my screen. I'm very pleased to be with you this afternoon. And again, SELNET is a great example of international collaboration. Not easy though to speak on novel treatment in bone sarcoma, which are quite complex and resistant sometimes to treatments. I will talk first about the novelties on Osteosarcoma. The last couple of years have been exciting for several prospective trials with the tyrosine kinase inhibitors. I want to mention that the last was a trial from the CAG group with Circulating, which is a dual SARC BCR-ABL inhibitor used as adjuvant in post-metastasectomy. So it's a new kind of approach. There was a slight difference, but the result was considered negative. And for the phase 2 trial, we can see that apatinib from the Chinese group had the best overall response rate, but all was impressed by the median progression-free survival of the French study, the cabozantinib, which demonstrated superior duration of response as compared to other, and also apatinib. Regorafenib as an interesting 4-month progression-free rate, but yeah, they're quite close. And this is not surprising because they share some targets, but as you can see, they're very, very different in terms of power. For instance, apatinib is stronger as a fibroblast growth factor receptor inhibitor, while cabozantinib has a wider target, so that may account of some difference in response. And we know that we can combine these drugs. The Grignani from the Italian sarcoma group already presented in 2015 an interesting combination with the sorafenib and the everolimus and mTOR inhibitor downstream, achieving a PFS at 6 months of 45%, which is higher if we compare with the 4 months about 40. Identifying also a subgroup of best responders, so predictor of response in ERK1/2 and RPS2 positivity. There are some interesting other combination with chemotherapy. Nathalie Gaspard, also from French, is just started a randomized trial comparing the combination of lenvatinib and etoposide ifosfamide with chemotherapy alone, and we are very eager to see this effect. And also pazopanib was combined with topotecan in another study by Brian Van Tine. Unfortunately, this combination may be also combine toxicity, and those as to be taken into account when deciding in the future for these approaches, especially thyroid, asthenia, or pneumothorax. And this year, the group also from Brian Van Tine presented a novel approach, I think, including a combination of metabolism target. We do know that phosphoglycerate dehydrogenase, it's activated and important in osteosarcoma, and dual inhibition with the NCT503 and those mTORC inhibitors, Circulating and ALP, was able, as you can see on the right, in this mice model, to see energize in reducing tumor volume. Of course, it's preclinical and has to be proven effective and also tolerable. In Ewing, there are several new targets that were explored, TKIs, mTOR inhibitors, the DNA damage response PARP and ATR inhibitors, or also novel Ewing WSR1 and FLY1 inhibitor, and other epigenomics and cell cycle drug. The results, the best results with the tyrosine kinase inhibitors is still with cabozantinib, with the partial response of 26% and 4.4 months of progression-free survival. Dual inhibitor insulin Hygro factor and insulin receptor trial results are still not published, but no partial responses documented. And also there was a study by Steven Attia, which included 30 Ewing. One was actually a chick ducks in a tumor with 10% of partial response, presented as an abstract. PARP inhibitor was one of the most appealing target. This enzyme is a poly-ADP ribose polymerase, which repairs single strands breaks in DNA. And as you can see in this slide, Ewing sarcoma, preclinically, the blue bars respond much better as compared with osteo, the red and the soft tissue. In the clinic, disappointingly, very no objective responses almost, either with the PARP inhibitor or PARP combined with chemotherapy like trabectedin in the study Thomas Wright Italian sarcoma group, or the SARC study, niraparib to plastimozolomide, while last year Rashmi Chung presented the combination with irinotecan, and the one partial response among 12 patients was reported. And the study from Massachusetts General Hospital is ongoing. So we need new drugs, and last year at ESMO there was much enthusiasm for a first-in-class new drug, which is a TK216, which was used in 23 patients available for recommended phase 2 dose, and the median PFS was short, only 1.8, but the interest was raised because 2 patients achieved long-lasting complete response. So it's a 9% overall response rate, and for a disease control rate of 43%. So maybe it's early, maybe we need, of course, predictive biomarker, but interesting. I want to spend some words for Chondrosarcoma because finally in this rare disease and chemo-resistant disease, we have prospective data. Firstly, there were presented and are going to be published the result of Eurobus trial, which included the differentiated Chondrosarcoma and a 5-year overall survival of 46 for localized patient was demonstrated, and also collaboration of Istituto Ortopedico Rizzoli with Harvard demonstrated superior survival for patients receiving adjuvant chemotherapy. So the differentiated Chondrosarcoma is now retrospectively and prospectively confirmed the utility of chemotherapy. As for conventional Chondrosarcoma, there are several tyrosine kinase inhibitor used in the past, several phase 2 trial with some partial responses and a median progression-free survival among 5 months. I want to concentrate on 2 interesting studies presented last year. One with an IDH1 inhibitor from Will TEP. This study also included 6 the differentiated chondros, so this is always the problem by selection of the patient. But as you can see, 4 patients achieved disease stabilization for over 2.5 years, which is clinically important. And also Dr. Senchavla presented at CITOS this DR5 agonist, which is a Tran receptor agonist. And there were also 2 patients, so 70% of overall response rate in this study, which is significant in conventional Chondrosarcoma, which usually doesn't shrink. Immunotherapy was used in several prospective trials in Osteosarcoma. SARC-028, demonstrated 1 partial response out of 21 Osteosarcoma. No PD-L1 expression was not known, and the median PFS was very short, confirmed from other study. The French one in combination with endoxan, which demonstrated 1 partial response, but a very short median PFS. And then the experience from Italian Sarcoma Group and Oslo, which over 13 patients demonstrated no partial response, but we were able to analyze with the nanostring technology the PNEO3060 signature, which demonstrated that in a case with a mixed response, that tumor has heterogeneity also either in PD-L1 expression. This is a PET scan which shows tumor response in those lung nodules which had PD-L1 expression. And this is the patient with a response which has a signature which separate very well from the other patients. So there is some probably predictive factor which we still need to find. And at ASCO, I presented the result of the Immunosarc bone cohort in collaboration with the J Sarcoma Group and the Italian Sarcoma Group. The this study on 40 patients demonstrated 1 partial response in case of osteosarcoma and 1 complete response in a patient with a dedifferentiated chondro, and this is the 3rd study now confirming that the dedifferentiated chondro has about 15 to 25% overall response rate with the immunotherapy or immunotherapy combination. So it's something that we should consider, and translational research on these samples is ongoing. We performed with a lab in Bologna a preclinical model, and sunitinib is able, in fact, to drive the dendritic cell full maturation and also to induce interferon gamma production and parallel to abrogate Treg induction. So there is a rationale to use this combination, this immunomodifier, and this model can be used for novel DC targeted drug like toll, like receptor drug, and CD47. CD47 is a new target which is also called DAN-8-me signal, which reduces the activation of macrophage, and there are several studies ongoing with this new approach, either former or new generation compounds, which is bispecific and may be more powerful. Talking about immunotherapy in bone tumor, we should mention also the study by the pediatric group presented at ASCO by Paula Ingorani. They use the inituximab, which is an anti-GD2. This target active recalls in the immune infiltration, linking to ganglioside GD2, which is highly expressed in several pediatric tumors, including osteosarcoma. Is also expressed in neuronal tissue and causes a lot of pain, like neuronal pain, but there's a 20-hour infusion which decreases these side effects, and the drug is now approved in neuroblastoma with this schedule. The primary endpoint in this adjuvant study, they included 39 patients with osteosarcoma and resected metastasis, was objective disease control rate at 12 months, and the target was 40%, but the result was 31%, so below the target, and 20% was the comparator from the negative collection of study published by Langbein in 2016. And we cannot talk about immunotherapy without mentioning CAR-T, chimeric antigen receptor adaptive immunotherapy. This approach targets several molecules, in particular in osteosarcoma. There is a rise interest in this target called the B7H3 on APC expression, but also in osteosarcoma, and is expressed highly and in a homogeneous way. And the group from Stanford, Robert Meisner, presented in clinical cancer research this study that shows how these CAR-T are able to inhibit tumor growth. And now a clinical trial just started. last word on ultra-rare bone sarcoma, because to treat, we need to know and to properly classify. This is a paper produced with my pathology, trying to classify ultra-rare tumor by main morphological features. So we know that not all round cells are same. And last year, the WHO classification nicely separated Ewing sarcoma from chick ducks and B-corm genetically. And this tumor can affect either bone or soft tissue. And this is a study from Professor Scotland lab showing how in 4 cases of Ewing sarcoma and 4 cases of CDX4 tumor, how nicely these genes separate. So these are really different entities, and with an RNA-seq enrichment analysis, 4 pathways were identified, and this led to identify 7, most importantly, differentially expressed genes. In particularly, the pathway of insulin Hygro factor binding proteins was studied, and combining trabectedin, which is able to link in downstream in nuclear level to insulin Hygro factor binding protein, and dual inhibitor, PIK3 and mTOR inhibitor, they were able to abrogate the tumor volume growth in a synergic way in this model, and also to improve survival of the patient. And this is due to the profound difference in between CDX and Ewing. As you can see, CDX tumor have ERK signal abrogated, so they are totally dependent on AKT mTOR signaling. And other groups presented genome-informed target therapy for osteosarcoma based again on PDX model of osteosarcoma, identifying that somatic copy number alteration were linked to tumor-specific dependency. And so to conclude, we have for the metastatic resistant patient, we in the past had the old approach, which still we use high-dose ifosfamide and gemcitabine taxotere for osteosarcoma. For Ewing sarcoma, there are the several combinations still on studied within the recur trial, high-dose ifosfamide, temozolomide, irinotecan, topotecan, and doxan, gemcitabine, taxotere, and now carboplatin and etoposide. For chondrosarcoma, there are several retrospective studies addressing the role of adriamycin and cisplatinum, and ultra-rare bone sarcoma are treated like Ewing with vincristine, adriamycin, and ifosfamide. But all the data that we now have suggests that MARC combo may be useful, including chemotherapy and lenvatinib or metabolism. In Ewing, excitement for first fusion-targeted drug, and LSD1 and CDK inhibitors trial results are expected. For chondrosarcoma, I'm really glad that finally we have prospective data, either in chemotherapy and also promising new target phase 1, like the R5. Immunotherapy is not as checkpoint inhibitor alone the solution for bone tumors, but some interesting preclinical results and suggest that adaptive immunotherapy or bispecific antibody targeted innate immunity might be more successful. And of course, for ultra-rare bone sarcoma like CHICDAX, BCOR, we need models. They are very aggressive, and I think that we have already the demonstration that PDX might help. And of course, we need in this ultra-rare or rare tumor, the collaboration, and I'm really, really proud to be part of this amazing group, which make this collaboration much easier. And I conclude just with an invitation. I didn't mention giant cell tumor of bone because the denosumab is not that novel, but if you have any advance in the giant cell tumor strategy, which you want to present, I'm hosting this special issue in cancer. And I really thank you for your attention.
Thank you very much, Emanuela, for your lecture. Really was really good. Excellent. So we are going to the questions. We have 6 or 7 minutes. Andrea, Gisela?
Yeah, good afternoon, everyone. There is some questions from Martin Angel about that you say in the conclusion, the combination of lenvatinib and pembrolizumab or regorafenib and nivolumab showing surprising response rates in other tumors like kidney cancer. Do you think that it is feasible in osteosarcoma?
I really appreciate your question because I was reading it last night, and it's shocking, like this, pembrolizumab, and it was the pembrolizumab, etoposide, and the imatinib, everolimus, and
lenvatinib.
And lenvatinib, yes. It was shocking how progressive was the increase of response rate with these 3 drugs in kidney cancer, which is a really good example of immune, but also TKI sensitive tumor. With so I think it's definitely worth trying in the setting of sarcoma. Now that we have the dose also and the feasibility.
Another question from Javier Martin Broto. What should be the main endpoint for advanced resistant osteosarcoma in terms of PFS rates at 6 months?
I like PFS at 6 months because it's comparable, and because overall response rate in disease is not always represent the disease response. So I think yes, PFS at 6 months it's very meaningful, and we know from several study now perspective that when there is activity, we are able to achieve 40, yes, I would say a 40%, 45% at 6 months should be regarded as an active treatment.
Okay, a question from Matías Chacón. Do you think that we have to spend more research time in drugs or in biology in bone tumors?
I think it's a very good question, because in no other, I think, disease as osteosarcoma, we are really frustrated from the failures of several trials, either in adjuvant and in metastatic disease. So and also most of preclinical data did not translate, I would say all preclinical data did not translate in clinical activity. I want to suggest and it was the point of the presentation, that maybe we need better models, and maybe now we have. So I think that getting back to the bench would be important now that we have better models.
Okay, there is another question from Nadia Indy. What would you be your proposed design for a clinical trial for therapy of Invictus sarcoma or Hygro sarcoma?
I think that it's really tough to run clinical trials in this ultra rare tumor, but with collaboration we can. And I know that we are already participating in a clinical trial in CHIKDAX4, and data with trabectedin and dual mTOR and IgA insulin Hygro effect and mTOR and trabectedin should, I think we should definitely study also that, especially in soft tissue tumor. We should at least consider trabectedin monotherapy activity. That might be also done as a compassionate use. That can, I think that can be done over a retrospective collection, since it might be used.
There is a last question from Jonathan Tran about mTOR inhibitors might have activity against IGFR signal for 6-DUX and Hygro we use by in front line. We add temozolomide plus irinotecan by for 6-DUX. Others?
So in CHIKDAX4, temozolomide, irinotecan, together with mTOR inhibitor.
Yeah.
Okay, no, I never used this combination, but I did use temozolomide irinotecan combination in second line setting of CHIKDAX4, and the progression was really quick. So I think it's very early to say it, and we should collect some case, even retrospective, as I said, but I have the impression that these diseases are really fast growing. I see a nice response to radiation therapy, though, but yeah, we don't have this data yet.
Well, Emanuela, thank you a lot for your time. It was really a pleasure to have you at the SELNET meeting. So,
pleasure.
Thank you. So we are going to introduce Jonathan Tran from the Sylvester Cancer Center in Miami. So John, which are the novel therapies in yeast? Thank you for coming.
Thank you for the kind invitation. Can everybody hear me okay?
Yeah.
Okay.
The nature is real. The nature is real across your window or not?
Yeah.
Wow.
Okay. So I'm going to go over some of the newer data. And I just wanted to thank you for newer data for GIST, and I wanted to thank the organizers for inviting me to discuss this topic. There's been a lot of advances and a lot of new data and a lot of exciting therapies for our patients with GIST. Uh-oh, I don't know what just happened. Okay, there. Uh-oh. Oh, okay, I gotta go up to the, sorry, my apologies.
No, it's okay.
Fun with Zoom, here we go. So we all know about GIST and what it is, but just to refresh everybody, for imatinib, the median PFS is 24 months, 6 months with sunitinib, 5 months with regorafenib. Newer agents we're going to see, such as Reprotanib, have a 6.3 month PFS, and avapritinib in 4th or 5th line and non-PDGFR mutated GIST patients has a PFS of about 4 months. Avapritinib, however, against PDGFR mutated patients, has a PFS that's not even reached yet. The response rate is somewhere near 90%. I also wanted to remind everybody that GIST is really a collection of different molecularly defined diseases are treated differently, honestly. Each of these entities has a distinct treatment strategy, as you can see summarized on this slide. In the United States, at the end of last year, we published a study showing that in the United States, only about 30% of metastatic GIST patients are being tested for their mutation. And as you saw in the previous slides, it's a molecularly driven disease. So there's really no way to prescribe the appropriate therapy unless the mutation testing is done prior to treatment with a systemic therapy. And yet 70% of patients in the US go untreated. So it's clearly an opportunity for us to improve. One way to improve is the advent of circulating tumor DNA. And this is because tumor cells, as they divide or die, shed DNA into the bloodstream with technology now available to not only detect the circulating tumor DNA, but also to quantitate it and to do molecular testing, DNA mutation testing. And so in a study, that we published in JCO Precision Oncology, we found that the most common mutation we could detect in circulating tumor DNA was KIT exon 11, followed by KIT exon 9, and PDGF receptor can be detected too. There were a number of patients categorized as other that may or may not have been driver mutations and may have been noise from the ctDNA testing. However, when we looked at resistant patients, patients that were TKI resistant starting a new therapy, 57% of the time the resistant mutation is in KIT exon 17, and about a third of the time resistant mutations are in KIT exon 13. This becomes important when one is determining subsequent therapies. And it's important because of this type of heat map that shows differential sensitivity of resistance mutations to TKIs. If you look on the far left side of the slide, you'll see different TKIs. And then across the top, you see different primary mutations and different resistance mutations. So we think of exon 13 as a common one. Remember, about a third of patients, and about almost 60% in exon 17 resistant mutations. Why is this important? Well, it's important because, for instance, sunitinib is very active at exon 13, but not at exon 17. These other agents, more or less, have activity at exon 17, but less clear their activity at exon 13. And so this is an opportunity really to tailor patients' therapy based on circulating tumor DNA results potentially in the future. Now, this has not been validated in prospective studies, but it's a compelling approach. Now, with that background, Reprotanib was studied in the Invictus Study, and this is a study where 120 patients were randomized 2-to-1 to Reprotanib 150 milligrams a day versus placebo, followed until progression. There was crossover allowed in the study. The distribution of patients by age, race, gender, other demographics were fairly similar between the two groups, Reprotanib and placebo. However, the difference in the median progression-free survival was quite clear in this Kaplan-Meier analysis. You see the median PFS of 6.3 months with Reprotanib and only 1 month for the patients treated with placebo. The activity of Reprotanib was clear in terms of partial responses. There were no complete responses. There was a lot of stable disease at 6 weeks, and even at 12 weeks, almost 50% of patients stable. Now, interestingly, a subset of patients that responded well had a very long duration of response, as you can see in this swimmer plot. Many of the patients responded for well over 10 months. Now, the study also showed an overall survival benefit for patients when they were randomized to Reprotanib compared to placebo, even though there was a crossover built into the study. And so some of the patients that were randomized to placebo didn't survive to make it to crossover. And this really, really makes us think whether or not placebo studies in GIST are really going to be ethically acceptable in the future. I think that's worth discussing. The side effect treatment-related adverse events for Reprotanib were alopecia, myalgias, and then some of the more common TKI side effects, such as nausea, diarrhea, muscle spasms, etc. So the Invictus Study showed that lead to approval in the USA for fourth-line therapy versus placebo with a 6.3-month median progression-free survival. Overall survival was also favorable. Importantly, 29 patients of the 44, 66% did make it to crossover and benefited. So the overall survival might actually be underrepresented, but however, 34% patients did not make it to crossover. Now I'll shift gears and we'll talk about the Navigator study. This is avapritinib patients with advanced GIST. This is the phase 1 expansion study, only 46 patients randomized to determine the randomized phase 2 dose. Once that was determined, the expansion study allowed additional patients, 121 in fourth line, and 43 patients with PDGFR alpha mutation. Now in this study, the exon 18 patients were fairly similar to the fourth line plus patients. Of note, the fourth line patients had more prior lines of therapy, of course, and the PDGFR patients had slightly larger tumor. In terms of treatment-related adverse events, most importantly with avapritinib, again, there's some nausea, fatigue. A difference between other TKIs and avapritinib is the frequency, a higher frequency of anemia and the cognitive effects that can impact the patients, as well as periorbital edema, which in many patients is somewhat worse than it is in our GIST patients treated with imatinib. But the grade 3/4 toxicity was fairly low, again, under 10%. Now this waterfall plot is a true waterfall. It's nice to see that the majority of patients, almost 95%, had some degree of tumor reduction when the patient had a PDGFR alpha exon 18 mutation. The vast majority of these were D842V, but there were other PDGFR mutations included in the study. There were a number of patients with partial responses, 34, stable disease with a combined objective response rate of 86%. Now in fourth line, patients with KIT mutated or any other type of GIST were allowed to enroll. And in fourth line plus, there was a 22% objective response rate. You can see the majority of patients had some tumor reduction. 22% met the criteria for partial response with a clinical benefit rate of 41% and duration of response greater than 10 months. This represents the patients who responded to therapy and had durable responses at around 10 months. So in conclusion, Navigator trial did show that there's activity, remarkable activity against exon 18 mutant GIST and PDGFR, but also some activity at fourth line plus. Unfortunately, the registration study comparing avapritinib to regorafenib was not found superior to regorafenib. So it's not approved in third line therapy, but is approved in the US for PDGFR mutated GIST. Now I'll say a little bit about a new agent that's in clinical trial currently called PLX 9486 from Plexicon, and this is the 12101 study. And I'm going to focus on part 2E of the study, where we combine PLX 9486 with sunitinib in 18 previously treated GIST patients at 3 different dose levels: high dose, medium dose, and then standard dose. Dose level 3 is the standard recommended phase 2 dose for both of these agents. And you can see there's a fairly even distribution across the different dose levels. Importantly, the median progression-free survival was fairly low. It was about it was only for the patients that received low dose. So at dose level 1, where they received low dose PLX and low dose sunitinib, the median progression-free survival was only about 3 months. However, when you increase the dose of PLX 9486 to recommended phase 2 dose, the median progression-free survival is 6 months. And then when we treated patients with full dose PLX, full dose sunitinib, the median progression-free survival was 12 months, which is, I realize this is a phase 1 study, but is almost double that reported with Reprotanib. And I'll give you some examples of how the future might be looking for us as we're managing our GIST patients with these new agents and with circulating tumor DNA. On the far left panel is the baseline imaging of a GIST patient with KIT exon 11 mutation who is found to have an exon 17 resistance mutation at 823D. This patient could have been treated with any number at the bottom of that heat map I showed you. We were able to get ponatinib for this patient on a clinical trial and had a response to therapy at exon 17 that was durable for more than a year. Here's another example of a patient with a KIT exon 11 mutated GIST with KIT exon 13 V654A resistance mutation, placed on a TKI. This is the baseline at the far left. This is a new liver metastasis, and then placed on a TKI such as avapritinib. And the patient, this is an exon 13 resistant mutation. So the patient's tumor grows through avapritinib because it's not so effective at exon 13 resistance. However, the patient was transitioned to sunitinib therapy, and sunitinib, on the other hand, is very effective at KIT exon 13 resistant mutations. So circulating tumor DNA may be able to help us determine optimal treatment for our patients in the future. It's non-invasive, so there's compelling reasons to it, and you can follow the results serially. So in conclusion, mutations really matter. We have to understand the mutation in order to pick the primary therapy and possibly the resistance therapy in the future. Avapritinib and reprotanib are active. Will they have a role in earlier lines of therapy or adjuvant? We don't know. Is there a role for combinations such as PLX 9486 and sunitinib, which provide complementary inhibition of exon 13 and 17 resistance mutations? I'd like to thank the GIST and sarcoma team here in Miami, and I'd like to thank everyone for attending today. And again, thank you for allowing me to speak on this important topic. And I would be happy to answer any questions or have some dialogue and discussion. And I'd like to thank Dr. Chacon for inviting me, who's a GIST expert himself and could have easily given this talk as well.
Thank you, John, for your presentation. Excellent, as usual. We have several questions from the audience. The first one is do you think if 800 of imatinib is still some role in the pathway or in the way of a GIST patient, considering the number of lines that you have right now?
Yeah, that's a great question. And I think there is a role for 800 milligram dose in patients with, we use it in patients with KIT exon 9 mutation and we use it in patients who are tolerating the 400 milligrams reasonably well. The problem is if a patient has severe edema or severe nausea, you may not really be able to escalate them to 800. So we don't treat everybody, but we do treat select patients.
Okay, Sean. Another question from Nadia is if you think that the avapritinib should be or had been compared with placebo instead against regorafenib as reprotanib in the Invictus trial.
Yeah, I think if it had been compared to a placebo, it might have had a chance of being found superior in 5th line or plus patients, because we know placebo patients do so well. The question, is it ethical to put a patient on the placebo study is the bigger question. But, you know, we've proposed talking to the FDA in the US and NCCN about allowing 5th line plus use of avapritinib for non-PDGFR mutated patients, because it does have some activity, clearly, with a 22% response rate.
So that answers the question of Javier, that is, it makes sense to test avapritinib in 5th line.
Reprotanib?
Avapritinib in 5th line.
Avapritinib in 5th line. Yeah, I think it would make sense. You would just have to think about what you're going to compare it to, really. What would be the comparator arm? And I believe all of us are having increasing concerns about placebos.
Okay. Also, Nadia asked if do you think that genotyping should be included in GIST risk calculation for localized disease?
I think that's a fabulous question, Dr. Hindi. Very good question. And it hasn't been yet. There has been some investigation in metastatic patients as to outcomes. So it's certainly worth considering. And importantly, in the adjuvant setting, you really want to know if they have an imatinib sensitive mutation. If they don't have an imatinib sensitive mutation, they're not going to benefit from 3 years of adjuvant therapy. So determining the mutation is critical from that. Whether or not specific mutations predict higher recurrence rates, I don't know the answer to that question, but I suspect it does. We know that KIT 557, 558 is associated with higher mitotic, more aggressive metastatic disease, faster growing tumors. So I would suspect that one may be, a risk for recurrence, particularly in the absence of imatinib. So you can maybe make the case, maybe this is a good research proposal to look at the patients that have intermediate risk and see if mutation could stratify and separate that group into higher risk and lower risk. Great idea.
Claudia Valverde asked if you have any comment, because we know that imatinib is the best first-line treatment in most of GIST, but which is your comment about the combination, as we saw in the last meeting, the binimetinib plus imatinib in first line?
First-line therapy?
Binimetinib plus imatinib.
Oh, I see. Yeah, I think that's an interesting combination. It's going to mean that I think it's a great question. Imatinib plus anything in frontline, I believe, are good questions. And so Benny is certainly a good question. The issue is that the response rate is so high and the PFS so long with imatinib. It really takes a lot of patience to find a small difference. And so it would be a challenging study to do, but I think it's a very good question. It would have to be a global study too.
Okay, so which is your concern about, because you talk about all mutated GIST, which is your novel therapy to wild type GIST?
Oh yeah, so that's a good question. So we end up, I would say today, if you do enough testing and you can't always do it because there may not be enough tissue, or it may be too expensive, or tests may not be available. But today, in my experience, probably 99% of just patients will have some type of mutation.
Mm-hmm.
The ones that have absolutely zero mutations in any gene would be considered a true wild type for everything. But I think that that's actually pretty rare. But the ones that are wild type for KIT and for PDGFR, one of the more common is SDH deficient. Matthias and I have worked together on this subset of patients some, and we know that they don't really respond to imatinib. There may be some response to regorafenib and sunitinib, the VEGF receptor inhibiting pathways. It would be interesting to see HIF1 alpha, HIF2 alpha inhibitors in the SDH patients, because we know it's in the pathway of SDH. But we don't have a great treatment for those patients. There is an ongoing trial we have for temozolomide in SDH deficient GIST based on the activity of temozolomide in SDH deficient paraganglioma.
Okay, John, and the last question, because we are on time. We know that cabozantinib is emergency therapy in every tumor. Do you have any experience with cabozantinib in 4 or 5 line?
I haven't used it yet, but the data that Patrick Shofsky presented looks compelling, and the in vitro data look compelling. But I don't have any experience with it yet.
Okay. Well, thank you, John, very much for your presentation. Very nice day in Miami. So I guess we are on time. So we let Javier to close the session. Really a very nice time for everybody. We have more than 90 attendance during the webinar. So for us, we are really very comfortable. We are very happy. So Javier, it's all yours.
Thank you, Matthias. It has been really a big pleasure to have these luxury speakers, Yaniv, Manuela, and John. Thank you very much, all the attendees. I think these lectures have been very stimulating for us, and we have prepared a very nice program for this year with 5 webinars within SELNET. And please turn on the camera. I would like to make a photograph. So if everybody can turn on, we have had almost 90 attendees this afternoon in Europe, morning in Latin America and America. So thank you very much for your attendance, and we will be able to upload this presentation in SELNET website. So and for those who need attendance certificate, please write an email to David Moura, as he has written in the chat. Thank you very much, and see you soon. Take care. Bye-bye.